Otosclerosis. So first of all, I will teach you what is the basic concept, what is the basic anatomy. So just focus on the screen. This is your middle ear. If I draw a simple line diagram for you, this is your middle ear, this is tympanic membrane, and this is your medial wall. That is what we call it as promontory. So in this middle ear, we are having three ossicle malleus incus stapes. Am I understandable? Somewhere, let us crack that word. Otosclerosis. There is a sclerotic lesion. There is a sclerotic lesion in the ear. It can be in the middle ear. Yes, it can be in the inner ear. So just before starting this topic, never ever make the concept otosclerosis something to do with the ossicle only. No, it can be anywhere in the ear. Maybe in the middle ear, maybe in the inner ear. Am I understandable? So what are the common sites? Just focus your eyes. I have highlighted this area, attachment of stapes. So where is the attachment of stapes? I will go in the depth of this segment. This is the most common site. Am I understood? But it can also occur in the cochlea. It can be in the cochlea. So this can be the lesion number 1. This can be the lesion number 2. Am I understandable? So otosclerosis. What is the definition? Like if you are my third year student and I'm asking you the Viva, in the Viva I will be asking you the definition of otosclerosis. Just remember two words, Peter. Just remember two words. There is a spongy bone. Just make a concept. There is a spongy bone which is replacing the aortic capsule. It is replacing the aortic capsule. So what is the basic pathophysiology? Because of multiple factors. We'll go in the depth of this segment. There is a dense, normally in a normal human being, there is a dense aortic capsule which is being replaced by spongy bone, So this word should be there. Am I understandable? Are you getting this point? So what is happening in the otosclerosis? Because of multiple factors, the dense aortic capsule is replaced by your spongy bone. Now I will be taking you the simplest MCQ. Deafness. In otosclerosis, whenever the middle ear is involved or inner ear is involved, what will be the common symptom? The logic say it will be hearing loss, it will be deafness. So the first important point, what will be the symptom? Symptom will be deafness. And now it depends on multiple factors. What is the pathophysiology? Why this spongy bone is there? It's precipitated by the hormonal changes of pregnancy, menopause, or maybe traumatic. So if the examiner asks you deafness, which is the most common presentation of otosclerosis, is conductive deafness. I'll be going in the depth of this word, conductive deafness. So just remember, deafness increases during pregnancy, menopause, trauma, all of the above. So answer will be all of the above. Am I understandable? So the first basic concept, sclerotic bone is replaced and multiple factors are there. Are you getting the concept? Okay. Now, what are the etiology? So your books mention multiple etiologies are there. It can be hereditary. It is an autosomal dominant condition. First point everybody should write. Otosclerosis, the first concept we have written. Whenever the word otosclerosis comes, the Viva question is dense aortic capsule is replaced by spongy bone. Now, what is the most common symptom? Because ear is involved, obviously it will be deafness. Now, what are the multiple factors? So just remember, multiple factors is a autosomal dominant condition. So if I give you 4 options, hereditary causes, endocrine, trauma, infections. So which is the most important is your hereditary, is your autosomal dominant condition. Am I understandable? Incidence of otosclerosis is overall more common in females than male. But if the examiner, like in PGI Chandigarh, they ask you this point. In Central Institute, they can ask you. In India, the incidence of otosclerosis is more in male. Important, worth remembering point. So out of multiple factors, endocrine, trauma, infection, vascular, autoimmune, which is the most important is hereditary. Endocrine is hormonal changes. Pregnancy is one of the important predisposing factors. So if you have attended my lecture before, I always say, if in ear MCQ, if the word pregnancy is there, always go for the otosclerosis. Am I understandable? Coming to the next point, which infection is associated with otosclerosis is your measles. And just remember, in ENT, in Viva, the 3 important points should be on your tips. Measles, yes, is associated with otosclerosis. Which infection is associated with sensory neural deafness? Is here mumps. Always remember mumps. And cytomegalovirus CMV is most commonly associated with congenital deafness. 3 points. Measles, otosclerosis, mumps, sensory neural deafness, and cytomegalovirus congenital deafness. Kindly respond. Is audio video fine? Yeah, is audio video fine, everyone? So these are the multiple factors. Related with otosclerosis. Clear? Now coming on the next segment. Is an autosomal dominant condition. What we have observed, sometimes a patient of otosclerosis, it is associated with blue sclera, with osteogenic imperfecta. If these three findings are there, so always remember, if these three findings are there, otosclerosis with blue sclera, with osteogenic imperfecta, it go in the favor of Van der Hoff syndrome. So the examiner can ask you, what are the three possibilities in Van der Hoff syndrome? Is otosclerosis with osteogenic imperfecta and blue sclera. Clear? Are you getting the point? So this is one of the important findings, is because of autosomal dominant condition is associated with the three conditions: osteogenic imperfecta, blue sclera. Now coming on types of otosclerosis, what we have learned, it is most common site. Where is the most common site? Most common site is here promontory. It is the promontory segment. Is a medial wall of the middle. Now I am giving you 5 options when the sclerotic focus is on the anterior part of the promontory. Now I am showing you a image. This is your stapes, this is your suprastructure of the stapes, and this is your foot plate. Now if the lesion is in the anterior part, of the foot plate, we call it as anterior foci. If the lesion is on the posterior part, we call it as posterior. So this is the anterior foci, followed by this is your posterior focus. And if it involves the whole of the stapes, we use a word circumferential. Am I understandable? Circumferential. So this is anterior, posterior, circumferential, which is the most common. Always remember, the other word we are using for otosclerosis is just remember this point, because it is on the anterior part of foot plate. So sometimes the examiner use a word fistulae. Everybody should write in a capital letter, fistulae antifenestrum. What does it mean? It means the disease is in the anterior part. This is the most common. Last Jipmer MCQ, most common variant of otosclerosis. So always remember, it is in the anterior part. So we use a word fistulae antifenestrum. It can be posterior, it can be circumferential, it can be on both sides. When it is on the both sides, we use a word biscuit type otosclerosis. So this is your biscuit type otosclerosis, and if it involves the suprastructure as well as the foot plate, we use a word obliterative. So just remember 5 types: anterior, posterior, circumferential. One is your biscuit and one is your obliterative. The MCQ was which is most common. So always remember, the most common is your anterior. And what is the other name of otosclerosis? Other name of otosclerosis is your fistulae antifenestrum. So these are the different type of otosclerosis. All the students who are joining just now, we have started the topic of otosclerosis. Always remember, auto, the word means ear. It's something to do with the ear. The lesion is in the ear. It can be in the middle ear. It can be in the inner ear. Am I understanding? Then types which are present on the promontory: anterior, posterior, circumferential, obliterative, anterior, posterior, circumferential, obliterative, and one is a biscuit type. Am I understandable? Out of which most common is anterior. Is an autosomal dominant condition in which the dense aortic capsule is replaced by spongy bone. What is the presentation? Because your ear is involved, obviously it will be your deafness. The examiner can ask you, deafness increased during. This was one of the recent MCQ in the NEET examination. The answer was all of the above. Out of multiple factors, if examiner asks you which is the most important, that is hereditary because it is autosomal dominant. If any of the MCQ word pregnancy is there, ENT MCQ, go for otosclerosis. 3 important infections which are worth remembering in ENT: measles, otosclerosis, mumps is your sensory neural deafness, and cytomegalovirus is congenital. Am I understandable? These points should be on your tips. Van der Hoff syndrome, we have learned 3 parts of the Van der Hoff syndrome: Van der Hoff triad, otosclerosis, Australian imperfecta, and your blue sclera. Clear? Now, coming on the next segment, once the patient comes, what is the most common? Most common is your deafness. Most common presentation is deafness. Now, it is bilateral. Always remember, it is a bilateral. Which one? Bilateral conductive deafness. Just remember this point, bilateral conductive deafness. And the word is there, progressive. Always remember. Now, here I will give you important concept in MCQs. If the examiner have mentioned the word fluctuating, the fluctuating deafness, always Meanies should click in your mind. And if the examiner use the word bilateral progressive conductive deafness, is damn sure is for, they are talking about for otosclerosis. In PGI Chandigarh, they have used the word painless. Yes, is a true word for deafness related with otosclerosis. Clear, whenever there is an infective pathology like ASM, the patient may have the pain in ASM, but in CSM obviously the patient will be having a painless. But if the examiner is using the word painless, bilateral conductive deafness precipitated by pregnancy, always go for the otosclerosis. Clear? Now, after learning this concept, compare progressive otosclerosis, fluctuating meanies. Now just learn important concept in audiometry in your hearing loss. Whenever the patient is having deafness, it can be of 3 types. One can be conductive, one can be sensory, one can be neural. So we basically divide in conductive and sensory neural. So just remember one point. If the patient is having conductive deafness, everybody please listen nicely, listen carefully this concept. If the patient is suffering from conductive deafness, whenever this patient will be going to a noisy surrounding, whenever there is a noisy surrounding, the patient will be feeling comfortable. Why? Because everybody is speaking loud. Everybody is speaking loud. The threshold is reaching somewhere 40-50 decibel. Patient is very comfortable. We use a word, paracusis. We'll see. So this is not only for otosclerosis. It is for any patient suffering from conductive deafness. Any patient suffering from conductive deafness is here. Paracusis will see conductive deafness. And if the patient is suffering from sensory deafness, like Meniere's, there is an important concept. Sensory deaf, whenever the lesion is in the cochlea, these patients are very oversensitive. So beyond 60-65 decibel, they are very oversensitive. Inner ear gets stimulated. This patient get uncomfortable. He become very uncomfortable because of vestibular symptoms. So whenever a patient of sensory deafness, listen carefully, a patient of Meniere's going to a noisy surrounding, he feel very uncomfortable. Why? Because vestibular symptoms come in the picture. We call it as Tullio's phenomena. So this is an important clue to differentiate conductive from sensory neural. If the patient is feeling comfortable, C for comfortable, conductive deafness. What is the phenomenon known as? We use a word paracusis, we'll see. And if a sensory patient, is going to a noisy surrounding, he is very uncomfortable. Tullio's phenomena, and this oversensitivity, the phenomena oversensitivity, is known as recruitment. So you should be confident of these words. Take my word. At DAMS, what we people are doing, we are teaching the basic concept. If your basic concepts are clear, take my words, you can crack any level of MCQ, whether it is INI-CET or it is a NEET examination. So just as for audiometry is concerned, oversensitivity is a phenomenon seen in which one? Sensory patient. What is the phenomenon known as? Recruitment phenomenon. Clear? Is known as recruitment. Because of recruitment phenomenon, patient is feeling uncomfortable. That uncomfortable part, that symptom, that presentation is known as Tullio's phenomena. So in the examination, if the examiner mentioned the word comfort, we go for conductive deafness. Patient is uncomfortable in noisy surrounding. That is sensory deafness. Clear? If a patient of otosclerosis, there is an involvement of inner ear, the patient may have vestibular symptoms. So vertigo is always uncommon. Why? Because most commonly the middle ear, promontory is involved, the foot plate of stapes is involved. But if the cochlear segment is involved, the vertigo can be there. Am I understandable? Because it is a conductive deafness. Just remember, conductive patients always speak very soft speech. The speech will be soft. Always remember. So in OPD, if the patient is having a very soft speech, never feel that he is a humble patient. He is a conductive deaf patient. Because why? Because patient having conductive deafness, there is an abnormality in the middle ear. When there is an abnormality in the middle ear, there is no disturbance coming when he is speaking out. So whenever he speak out, he perceive his own voice in a very comfortable way. So the patient is having his own voice very nicely, so he always have a low intensity speech. So soft speech is equal to conductive deafness. It is not only for otosclerosis, any conductive patients. And while sensory patient, like I am suffering from sensory patient, my sensory deafness, and my cochlear requirement is somewhere 60-70 decibel, or my inner ear like auditory neuropathy, 8th nerve is involved. Sensory neural auditory neuropathy. If my 8th nerve is involved, my requirement will be somewhere 60, 70, 80 decibel. So I will be speaking somewhere at that voice where I will perceive my words. So I will be having very loud voice. I think you are getting my point. Till now, I have given you two nice concepts. Patient feeling comfortable in noisy surrounding, conductive. Patient having soft spoken voice is equal to conductive deafness. Patient loud voice is your sensory neural. Patient feeling uncomfortable in noisy surrounding is equal to sensory. These small points helps a lot, because in a lengthy MCQ we are moving from NEET to the next pattern. In the next pattern, when the examiner will be giving you lengthy MCQs, there will be a keyword. That keyword will help a lot to make that diagnosis. Are you getting this point? So these are the important features. These are the important points related with otosclerosis, finding of the otosclerosis. Now, if you are my Viva student, I will be asking what are differential diagnosis. Whenever the patient, the otosclerosis, the foot plate is involved, what can be the option? It can be fixed Malay syndrome. I have written one. It can be serous otitis media. But the difference will be, I will be helping out how to differentiate serous otitis media, secretory otitis media, ASM from the patient of otosclerosis. That would be a bulging tympanic membrane. Am I understandable? Are you getting this point? Fixed Malay syndrome, secretory otitis, congenital fixation of the stapes. Yeah, one of the most common. It is the most common pathology of congenital abnormality of middle ear, ossicular discontinuity, or it can be tympanosclerosis. So these are the 5 important differential diagnosis of otosclerosis. Again, fixed Malay syndrome, secretory otitis media, SOM or ASM. It can be congenital fixation of stapes or malleus, or it can be tympanosclerosis. Now, how to differentiate infection part? Now listen carefully. Congenital fixation or ossicular discontinuity, there will be history of trauma. Now let us go in the depth of this segment. There will be in the MCQ, the examiner will mention a history of trauma. There will be a trauma, patient landing up. There will be no such history in case of otosclerosis. Am I understand? Fixed Malay syndrome. Yes, fixed Malay syndrome. Again, the patient will be having on CT examination, we can differentiate in serous otitis media or ASOM. Serous otitis media or ASOM. Just remember, tympanic membrane will be bulging tympanic membrane. Patient will be having high-grade fever. Now, the third point. In otosclerosis, tympanic membrane will not be bulging, but it will be reddish. Just remember this point. Differential diagnosis of reddish tympanic membrane. I am showing you one tympanic membrane. This is a reddish tympanic membrane. There is a reddish hue on the tympanic membrane. Two possibilities. It can be ASOM. Yes, it can be ASOM. If the patient is having high-grade fever, if the tympanic membrane is bulging. But if there is no high-grade fever, there is a reddish tympanic membrane, we go in the favor of Schwartz sign, also known as flamingo pink sign. So if a female comes to you with bilateral conductive deafness on examination, we have seen a reddish lesion on tympanic membrane. If no fever, no bulging tympanic membrane, ASOM ruled out. If there is a high-grade fever, we will be going in the favor of ASOM. This is Schwartz sign. What is the importance of this? short sign. What is the importance of flamingo pink sign? Capital letter, right? This point is a contraindication, of, just remember this point, contraindication of surgery. We can never operate if there is an acute phase. If there is an acute phase, we cannot operate the patient. I'm understanding short sign. It means whenever the patient give you this finding, always go for medical treatment. We will be going for medical treatment. Clear? So short sign, flamingo pink sign is a otoscopic finding, is a contraindication of surgery. Always remember this point. Now I will take you to the next level. Whenever you will be seeing the reddish tympanic membrane, just remember this point. It is for your third year prof examination. If you examine the tympanic membrane, reddish tympanic membrane, 3 points should click in your mind. It can be otosclerosis, what we call as short sign. It can be ASON. Which word we are using? We are using the word cartwheel appearance. Or the third possibility, in Viva they can ask you, it can be a glomus tumor, what we call it as rising sign. So better differential diagnosis of reddish tympanic membrane. Clear? So this 3 points should be on your tips. I'm trying, the way I'm teaching you, take my words, we are just concentrating on the keywords. Take my word, the students who have a habit of highlighting the keywords will get a good rank in post-graduation. Whether it is NEET examination, next examination, hardly matter. Just focus on the keywords. Am I understandable? Clear and concise. Whatever you are reading, like at the end I will be showing you how we will concise the whole topic of otosclerosis. We are going in the depth with differential diagnosis, signs, symptom, everything. But at the end, what should be your responsibility? Your responsibility should be to concise otosclerosis in 15 to 20 words. Those 15 to 20 keywords on which examiner will make the MCQ. That's it. Are you getting the point? Okay. So coming after otoscopic examination, I will be taking you to the audiometry. So in audiometry, what will be the finding? You tell me. What will be the deafness level? Patient is conductive. Conductive deafness is always mild deafness. Will be in the range of 40 decibel. So the patient will be having the threshold of 40-50 decibel on pure tone audiometry. And on pure PTA, pure tone audiometry, what will be the hallmark finding? Hallmark finding will be there will be a loss at 2000 hertz. There will be loss at 2000 hertz. What we call it as Carhart notch. Always remember this point is equal to, it will be seen in bone conduction. So now if you are my student, otosclerosis, Carhart notch, 2000 hertz, bone conduction. These are the only worth remembering point for MCQs. Otosclerosis, Carhart notch, 2000 hertz, bone conduction. This notch is seen in ear conduction, bone conduction, This is more than sufficient for your MCQs. Now I will be taking you to the Viva rule. In Viva, I will be asking you, better conductive deafness is abnormality of ear conduction. So why the loss is in the bone conduction? Then you have to reply. Okay, whenever there is a otosclerosis, there is a sclerotic foci, the bone conduction component of ossicle is increased. Normally the ear conduction dominates. But in otosclerosis foci, bone conduction component increase a lot. That's why the loss is in the bone conduction. This is one of the biggest exception of audiometry. Multiple hypotheses are there, but just remember this point because the bone conduction component is involved. First point. Second point, the resonance frequency of the ossicle. What do you mean by resonance frequency? At which the ossicle vibrate maximum. At which frequency the ossicle vibrate, that is 2000 hertz. So whenever the ossicles are involved, the bone conduction component is increased, and which frequency is involved, that frequency to which the ossicle are resonant. Which frequency? 2000. These are the Viva questions. Are you getting my point? If a third year student is listening to this demo session, these points are Viva questions. But in MCQs, just remember 2000 hertz, Carhart notch, bone conduction. That's it. Now the next point I have written SDS. So I'm taking you to the next level of audiometry, that is speech audiometry. In speech audiometry, they ask you speech discrimination score. So always remember, conductive speech discrimination score is very good. In sensory, it is poor. In neural, it is very poor. It is a depth of, whenever I will be teaching this topic of speech audiometry, I will be discussing these points. So just remember, whenever we do speech audiometry, we increase the threshold, we increase decibel, like we give 30 decibel, increase voice. So when we increase the intensity of these spoken words by 30 decibel, patient have a drastic improvement. Am I understandable? That's what we call it as speech discrimination score. It is very good. 50% will be jumping somewhere 90. So they can ask you what is speech discrimination score. So it is somewhere 90%. Am I understandable? Coming on the tuning fork, Reni's or Weber. Always remember what is the hallmark finding of conductive deafness. Conductive deafness, Reni's finding will be negative because bone conduction is now better than air conduction. BC is better than air conduction. Weber will be lateralized to worse ear, because it is bilateral beta. So we can't say it is lateralized to disease here. Here both the ear are disease, both the ear are involved. So it will be worse here. Weber worse here. So what will be the finding? Listen carefully. Audiometry, pure tone audiometry, it is Carhart notch, 2000 Hz bone conduction. Speech audiometry, speech discrimination score will be very good. It will be somewhere in the range of 90%. Reni's will be negative. Weber lateralized to worse ear. Ear absolute bone conduction. Obviously, absolute bone conduction will be reduced. What is ABC? Is one of the obsolete tests where we are comparing the bone conduction of the patient with the bone conduction of the examiner. So always remember the bone conduction, because the ear conduction is involved, the middle ear is involved. So ABC will be normal, but whenever the cochlea will be involved, yes, when the cochlea involved, the ABC will be abnormal. But this test is obsolete, but you should be aware that yeah, it will be normal because the middle ear is involved. But whenever there is a cochlear otosclerosis, even the bone conduction will be in. Now, what is the investigation of choice? So, my dear students, just remember whatever we are reading: pure tone audiometry, speech audiometry, Reni's, Weber. What are these? These are subjective audiometry. Last INI-CET exam, they have asked you this point: which of the following is objective? Investigation of choice is always objective. So, inverted commas, capital letters, write the word impedance audiometry. Impedance audiometry. Impedance audiometry is the investigation of choice. In impedance audiometry is a variety of investigation, and what we are doing tympanometry. So examiner can give you either the word impedance audiometry or they can give you the word tympanometry. And on tympanometry, which tympanogram is seen? Normal tympanogram is like this, A-shaped tympanogram, but in this otosclerosis, the ossicles are very stiff, sclerosed, so the mobility will be less. We use the word AS. So on tympanometry, beta, which tympanogram will be seen? AS type of tympanogram will be seen. AS type of tympanogram will be the finding. Clear? So I'm showing you a few things. This is your AS tympanogram, differential diagnosis of AS tympanogram. It may be otosclerosis, it may be otofibrosis, it may be tympanosclerosis, it may be tympanofibrosis. So all these are the differential diagnosis of AS tympanogram. Hypomobile, we use the word hypomobile. Tympanic membrane. Clear? Carhart notch, always remember Carhart notch is a loss at 2000 Hz. It is seen in bone conduction. So these are the important points which should be on your tips. Now, coming on the next point. This was a statement: Carhart notch disappeared after stapedectomy. Absolutely true. So what is the treatment? Now I am taking you to the treatment segment. Otosclerosis. Sclerosis, as for surgery, always remember. Just remember the golden statement: otosclerosis is equal to surgery, Meniere's is equal to medical treatment. In Meniere's, the first line of treatment is always medical, but in otosclerosis, the first line of treatment is always surgery. So what we people are doing, we are removing the sclerotic focus, which we call it as stapedotomy. 10 to 15 years back, the seniors, they used to do stapedectomy. They remove the whole stapes. So whether you are doing stapedectomy or stapedotomy, two important MCQs waiting for you. After surgery, after stapedotomy or stapedectomy, which are the two important changes? Just remember the tympanogram. tympanogram will not be AS. Now beta, you tell me, you remove the stapes. There is a ossicular discontinuity. So the graph will be AD graph. Graph will be AD graph. And what is the other point? The other segment is Carhart notch. The Carhart notch will disappear. Two important points. After stapes surgery, the graph will be shifted from AS to AD. Is a hypermobile now, and Carhart notch will be disappeared. Carhart notch will disappear. Clear? Surgical treatment. Now, if the examiner give you the word stapedotomy is a better option. Stapedotomy is much better than stapedectomy. Is better than stapedectomy. Clear? What are the differences? Obviously, whenever we are removing only some part of stapes, it will be more safer. There will be less chance of sensory neural deafness. Why? Because when you are removing the whole stapes, there is a risk you can do trauma to the inner ear, trauma to the cochlea. So there will be high risk of sensory deafness. But what is the drawback? Drawback is you are removing only the sclerotic foci. So there is a reoccurrence, high risk. But after stapedectomy, there is no chance of reoccurrence. This is an important point which you should remember. Am I understandable? I'll be showing you just how we keep the prosthesis. Once you remove the stapes, you can keep your artificial prosthesis which are made up of Teflon or stainless steel. I will be showing you this. First, I will be showing you the animation, how we proceed. Like just do imagination. We are going from a endometrial approach. Just try to see we are reaching the middle ear via tympanic membrane, raising the flap of tympanic membrane, but we use the word Rosen incision. Then we are removing the sclerotic foci. We are removing the stapes segment, and followed by we have to keep the prosthesis. So this is the first. I am showing you the animation. Just try to learn. Again, I am showing you the same image via endometer, via middle external auditory canal, raising the flap, Rosen incision. We are removing the stapes. After removing the stapes or sclerotic foci, we have to keep the prosthesis, which is commonly made up of Teflon. Now I am showing you this after discussing the animation. I'll just try to appreciate this one. We are going from the external auditory canal. All these videos will help you to appreciate whatever I'm teaching you, whatever you're writing. You will never forget. Now just try to see. We are going endometrial approach. Via endometrial, we are raising the flap. Now once we have raised the tympanic membrane flap, we are going into the middle ear. Just try to, with this all, we are raising the flap of tympanic membrane. We use a word Rosen incision, Rosen, R-O-S-E-N, Rosen endometrial approach. Then we are operating, we are in the middle ear now. We are appreciating these ossicles. Now at the end, just try to see this here. We have removed the stapes. Yes. Now after removing the stapes, we have to keep a prosthesis. I think with this video your whole concept is crystal clear. Yes, with the help of laser, we are removing the sclerotic foci. We are removing the superstructure of stapes, and finally we have to keep a prosthesis. Can you appreciate? Finally we are keeping a prosthesis. Okay. So all these things are the part of treatment segment surgery. Okay. So this is a basic treatment, treatment of choice of otosclerosis stapedectomy. But if the patient is having a contraindication of surgery, like we have learned Schwartz sign, we can't operate the patient. In that condition, we have to go for the medical treatment. Now you people tell me, what will be the drug of choice? Common sense. My second year, where any second student is attending this demo session, you should tell me, what should be my drug of choice? What should be the mechanism of drug of choice? Just use your IQ. If you apply the logic better, just remember in medical profession, MBBS never try to mug up the things. What we do in DAMS, we try to make the things very simple. Just close your eyes and do imagination. If you want to treat a patient of otosclerosis, you are a second year student, you tell me what should be the mechanism of action of the drug. The logic say your drug should increase bone, because what is the first line of my lecture? There is a dense aortic capsule is replaced by a spongy bone. Now the point from where we have started, we will wind up the session. In otosclerosis, the dense sclerotic foci is replaced by spongy bone. So what your drug should do? Your drug should increase the dense bone. means osteoblast. It should increase the osteoblast, and if it decrease the osteoblast, bone destroying cell, that drug will be very beneficial because it will be helping in reducing the presence of spongy bone. So my drug should increase osteoblast, it should reduce osteoclast, and the drug is sodium fluoride. So drug of choice, always remember, is here sodium fluoride, NaF. Sodium fluoride is the drug of choice. What is the mechanism of action? It increases the osteoblast, it reduces the osteoclast. Clear? Are you getting this point? Now, before winding up the session, what is the responsibility? When you attend this session of otosclerosis, you should concise the topic in 15 to 20 words. Otosclerosis is equal to pregnancy word. Just write hereditary. Most common, most important factor, hereditary. But if the word pregnancy is mentioned in any ENT MCQ, we have to go for otosclerosis. Is equal to bilateral, painless, conductive deafness. Conductive deafness. Once the word conductive deafness is there, we should be master is a mild loss, mild conductive deafness at 2000 Hz. Our heart notch is equal to bone conduction. Then it equal to good SDS. What we have learned is a good SDS, speech discrimination score. Rin is negative, Weber lateralized to worse ear. Is equal to investigation of choice, impedance, audiometry, bracket, tympanometry, bracket, AS, is equal to surgery. Stapedectomy is the treatment of choice. Stapedotomy better than stapedectomy. And just beneath we will write, after surgery, our heart notch disappear. AD graph is there. What is the drug of choice? You should write sodium fluoride. Bracket of sodium fluoride, you will mention increase osteoblast, reduce osteoblast. That's it. The main motive of conducting this demo session, main message I want to convey you. This is the way we have to concise the things. Otosclerosis, bilateral, conductive deafness, painless, pregnancy, hereditary causes, mild, 2000 heart notch bone. If we chew these words, if we revise these words again and again, take my word, examiner will give you one of these words as a key, as a clue in the MCQ, and you will crack, and your time management will be perfect. Am I understandable? It means in your NEET, whether it is NEET or next examination, is your number of the revision, how much you have revised. But what we have seen over the last 2-3 years, the students, they are running behind multiple sources. They are adding all the points better. We can't afford. Go for one source, revise 5 to 6 times. Take my words, nobody can stop you in getting a good rank, decent rank, your dream branch. Clear? One of the few miscellaneous points are always there. Like after completing this topic, I take you to the next. There is no upper limit. We have to stop somewhere, and we have to focus more on the revision segment. Now, cochlear otosclerosis, whenever there is a very rare finding, cochlear otosclerosis, what we see on the CT examination, because there is a spongiosis within the thickened aortic capsule, so we get a double ring effect. On CT, we get that is a finding of cochlear otosclerosis. Is the topic over? No. If you want to go to beyond this level, they can ask you on cochlear otosclerosis, there is a cookie bite audiogram, but very less rare possibility they will ask you these questions. There is a textbook of otosclerosis data. We can't go to the depth of each and every segment, but yes, what we have to do, we have to learn the basics. We have to make basic concepts strong, and we have to revise again and again. Clear? I hope this session will give you a vision how to proceed. I have taken a very small topic of otosclerosis. I tried my best to concise the topic, to teach you the basic concepts, how to compare, how to differentiate between conductive and sensory neural, how to differentiate the differential, how to go rule out the differential diagnosis of reddish tympanic membrane. All these basic concepts should be on your tips. Thanks a lot for listening to me. We people are there with multiple courses on the app, and the beauty of our courses, we all are having live courses. I'm understandable. We never believe in the recorded sessions. Anything which is recorded, take my word, is of no use. Why? Because it is somewhere recorded 2 to 3 months or maybe 1 year back. In medical profession, every day things are changing. Whatever is recorded we are giving you should be used for revision segment. I'm understandable. So just attend our live sessions. You can use my code. I am giving the code to get a discount on all these courses. Very best of luck. Thanks a lot for listening to me. Thanks a lot.